Thanks for opening that, Craig.
Sorry about that. I didn't know I was supposed to do that. Just give it a minute to let everybody get caught up on the admitting.
And then I don't know if you have to do anything special. Would you be able to give access to Shapiro, Naraki, and I to share our screens?
Yeah. So Alan is a co-host, so he should be good to share. Dr. Phil is a co-host. Is that you, Brendan, sharing?
That is not.
Yeah, I shared my screen.
Okay, I see it.
Okay, I was gonna go first just because I was overnight last night.
All right. Sorry for the delay, guys. I thought Jen was going to open that up. We got it going. I'll be writing the names down and I'll get her the roster here in a second. If I need any identifying help, I will ask you. But Dr. Naraki, you're up first, so you can go ahead and go.
All right, perfect. So thank you guys again for joining us, and thanks, Greg, for opening the meeting. So pretty happy to present this case this month. I believe this is the first RSI by physician Ross Westview provider since we opened up the that protocol for pre-hospital physician extenders. So all right, so again, all educational, none of this is punitive. It's a little bit harder to keep this one anonymous since there's only 2 PHPEs at the moment that are credentialed to RSI. This case was from just about a week ago. So there's a 27-year-old male weighing about 105 kilos with seizures. Initially dispatched as seizure unresponsive. So he was found on a carpeted floor. He was not responsive to any sort of stimulation, but was breathing well on his own. He was noted to have vomit around his mouth, no external signs of trauma. So in the impression, I think one of the themes of this case and chart is the documentation. I think is absolutely fantastic. So the impression not only is seizure, but we're considering other things. We're keeping our differential diagnosis broad, including trauma, as well as vomiting, unresponsive. So other history in the EMS documentation. He has a history per the father of weekly seizures, usually resolved by themselves without interventions. In this particular case, the dad heard a thud, went upstairs, found the kid unresponsive, was noted to have a grand mal seizure, lasted a few minutes, and he was noted to have vomit all over himself as well as in the oropharynx. It sounds like the dad had also made some vague statements about the patient having female issues or issues with his significant other, and there may have been some drugs or other medications in the house, but the dad couldn't find them. So in the physical exam section, this was the documentation that was provided. Take a look at this, think about it for a few seconds, and contrast it with some of the other documentation that we've shown in previous cases where, it'll say head findings, unremarkable, neck findings, unremarkable, chest findings, unremarkable. This chart does a really good job. Again, one of my biggest pet peeves is when we say unremarkable. I always say, whether it's normal or abnormal, you can remark upon it, right? So for example, under chest, there's no crepitus, there's no deformity, there's no tenderness. You can always remark upon something, even if it's normal. And this chart, again, does a great service of really noting all of the abnormal findings as well as the normal findings. So excellent documentation here. As far as the activity log goes, patient contacts made at 12:13. Vitals initially look okay. Over the next few minutes, we're managing that airway. We're suctioning, we're putting in a nasal airway, we're placing him on a 15-liter normal breather face mask. He then develops another grand mal seizure before he returned to baseline mental status. This one lasts 2 minutes. We gave 5 milligrams of midazolam. The seizure did stop after 2 minutes, but again, he vomits. And his SAT was noted to be 78% at that point. The patient was transitioned to the medic unit, and the decision was made shortly after to pursue rapid sequence intubation. And again, the actual chart does a very good job of explaining the rationale and the medical decision making to intubate the patient, which was, multiple seizures back to back without regaining full mental status, vomit in the airway, and the patient's clear inability to protect his own airway. So he's given 25 milligrams of etomidate, 100 milligrams of rocuronium. We used video laryngoscopy, able to successfully intubate him on the first attempt. Vital signs stabilized after this. And then finally, Keppra was given by the advanced practice provider, which we'll talk about in a bit. So this was the bit of addendum that was added on to the end by the advanced practice provider that was on the case. He was the one that had performed the RSI. And, I think this does a fairly good job of describing what had happened. I think in the actual activity log and the actual documentation, it's much more clear the decision-making process that went behind the RSI. The emergency department, it says a trauma alert was sent, but I don't see any notes from the trauma team, so I'm wondering if this was canceled. CT head was negative, no bleeding, no masses, nothing like that. They did perform EEG. They were able to perform EEG at bedside in the emergency department because he was paralyzed and sedated. They found he was not having any further seizure activities underneath the sedation and paralysis. His blood work looked normal. Further history from the father confirmed they did have concern for a possible overdose of an unknown drug. The patient was put on a propofol infusion. He was given IV pushes of fentanyl and I believe it was additional Versed because he was starting to wake up. Upstairs, they were able to extubate him the following day. His MRI was normal. They really found no clear reason why he was having these seizures, and they thought it was probably due to medication noncompliance. He was then transferred to UPMC for insurance reasons. So status epilepticus is really one of the more serious, time-sensitive medical conditions. A lot of times we don't think of it this way, but several studies have shown that you can start to develop irreversible brain damage within 5, 10, 15 minutes. And again, that's because the patient's hypoxic during this event. So early rapid control of that seizure is absolutely essential. So before you get there, if the dispatch information is telling you that they're still seizing, we want to consider, managing that patient's airway. So being ready to suction any vomit or blood that's there, using BLS airway adjuncts, putting them on a non-rebreather, or using a bag valve mask, with always the potential to need to intubate the patient. So initially, all the way on the left column here, we're going to start with our benzodiazepines. Whether it's Ativan, Versed, Valium, really doesn't matter as long as we're giving some sort of parenteral benzodiazepine. The next step, if they're still seizing after, I would say 3 to 5 minutes, would be either another dose of benzo or jumping to a second line agent, which, we're not carrying at the moment, but something like phenytoin, fosphenytoin, or going towards Keppra or valproic acid. If they're still seizing after this, that's when, in the emergency department, we think about putting them into a, phenobarbital coma, or giving them propofol and putting them into very deep sedation so they're not having any further seizures. And the definition of status epilepticus, I guess I should jump back to that, is important to remember. It used to be 10 to 15 minutes of seizure without stopping, but that's changed in the past few years to actually ongoing seizure activity lasting more than 5 minutes. And again, that kind of recognizes the serious nature of status, as well as the need for that urgent, immediate intervention. It's also considered status when, as in this case, the patient has a recurrent or a second seizure without fully going back to normal mental status. In terms of airway management, one of the slides, I think I include this in the airway management course that we do at Allegheny. The primary decision point really should be, does the patient need support or complete intervention and takeover? So if they just need, support, say this is just a typical, single seizure, we can use, our BLS adjunct. So they may be in respiratory distress, they may be altered, drowsy, somnolent because they just seized, but we don't need to actually completely take this person's airway. We just need to support it until the brain recovers and is able to breathe for themselves. So contrast that with the need to completely take over the patient's breathing. This can be due to respiratory failure. So in someone, with an underlying lung disease like CHF, pulmonary edema, pneumonia, that has tired out and they're not effectively breathing anymore. Or as in this case, if their airway is compromised, they're not ventilating effectively. So in these cases, we're completely taking the airway, we're putting in a supraglottic airway, an endotracheal tube, or using a bag to completely, support this person's oxygenation and ventilation. Again, I want to go back to the documentation, and again, I can't commend the crew enough for the solid documentation they did on this case. So for example, consider the following two scenarios. The first one, this could have easily been the documentation. The person seized, they're found to be altered, there's vomit, and the patient was RSI'd. So I think if you are not familiar with EMS, if you don't, understand what we do, or weren't familiar with this case and you read this, I think most people would say, why the heck are they RSIing a seizure? He was probably going to improve within a few minutes, as he was postictal at this time. He didn't need to be intubated, right? Because there are side effects to intubating patients. There's downstream effects. They have to go to an ICU. They can get ventilator-associated pneumonia. You can get lung injuries. You run into issues with sedation. So there are adverse effects associated with intubation to be considered. So it's not, a benign procedure. So it's easy, I think it would have been easy for someone to Monday morning quarterback if this were the documentation and say, this patient didn't need to be RSI'd, EMS doesn't know what they're doing, they shouldn't be RSIing patients. But in this case, again, the providers on this case did a fantastic job documenting, and it was much closer to this second example, which really spells out they're painting a very clear picture of what's going on with the patient and describing their medical decision-making of why the patient needed to be intubated. And again, we know rapid sequence intubation gives you better intubating conditions than just medication assisted, which is currently in the PA protocols. So again, I think we're doing a great job of really pushing the state protocols, and also really optimizing pre-hospital clinical care for our patients. So again, great job documenting. Makes it very easy to look at these cases and know that we did the right thing. So one point I wanted to bring up, after the patient was intubated, he was given Keppra, which is levetiracetam, which is another anti-epileptic medication. Clinically, I completely agree with this, because when you give somebody a paralytic like rocuronium, you don't know if they're still seizing, because you've completely taken away all their muscle tone. The only way to really tell is to do an EEG, which we obviously don't have in the pre-hospital setting. So clinically, absolutely correct. Brendan and I had talked about this a little bit, and our concern is that in the state protocols, these two medications are really only approved during interfacility transfer, or if it's a critical care transport ambulance. So just for the time being, we're going to ask that we hold on giving any further TXA or Keppra, and we're going to chat with Dr. Nesbitt about this, just to make sure that we have a uniform policy across the network and that we're in alignment with the state protocols. We're going through the ALS protocol very briefly. Again, we want to manage the airway, consider getting an EKG and a glucose reading, as those are two mimics of seizures that frequently pop up. If the seizure is continuing while we're on scene, that's when we really want to start our anticonvulsant treatment. So in general, we're going to be using the center column here for adult patients, either Ativan, Valium, or Versed. Weight-based dosing. There's also pediatric weight-based dosing, and then the big asterisk, if they're pregnant or if they're recently postpartum, we want to consider magnesium, because this could be eclampsia. A few additional points mentioned in the protocol. In pediatrics, fever is a somewhat common cause of seizures called febrile seizures. So if they're still febrile after their seizure and they're protecting their airway, we can consider giving acetaminophen, a weight-based dose. And then the second one, I mentioned IV magnesium, 1 gram per minute up to 4 grams total. If they're pregnant, generally after 20 weeks, or if they're postpartum. And then always good, again, to consider the cause of the seizure if there's some sort of infection. Generally, the most common ones are drug-induced, alcohol-induced, or alcohol withdrawal seizures, or the patient's just non-compliant with their medications. Anybody have any questions on the first case?
So for cases with vomitus and airway protection, how does endotracheal intubation compare with other supraglottic airways available?
So that's tough to say. I would say, one of the initial actions should be suctioning. You want to get all of that, as much as you can, out before you start putting devices in the airway and potentially pushing it further down. I think the benefit of endotracheal intubation is you have that cuff seated within the trachea. So if you suction appropriately, that cuff's in there, you're really creating a closed conduit between, the bag going through the endotracheal tube down into the lower respiratory tract. Whereas a supraglottic device, has a little bit more potential to push some of that vomit, blood, whatever it is, down into the airway. So yeah, it's probably ideal. Again, the vast majority of seizure patients do not need intubation. They all need airway management, meaning, the BLS adjuncts, proper positioning, suction. But most, simple seizure, single seizure with a postictal patient shouldn't require any sort of invasive airway management. All right, Brendan, I will turn it over to you.
Dr. Naraki. I just wanted to mention I was on the call with Bill and Fran, and some of the benefits that come away from that are certainly good patient care, but to see the methodical process going through the checklist when you have the opportunity to kind of take your time, make sure you're doing it right, and work through that as a team was really very good education for all of us. And I think it was an exceptional opportunity for Bill to participate in that and get that airway. But I just wanted to mention that to you guys because I think we have a unique ability to do that when Fran and Brendan and Brett are around, and there's tremendous takeaways for us from an educational perspective.
I didn't even need pictures to help me.
And there goes all of that education right down the shitter. Thanks, Bill.
You're welcome.
No, that's great to hear, and I'm glad the checklist is definitely a helpful tool. And when it comes to RSI, it's really about the process, right? It's about that streamlined approach to intubating the patient. Passing that piece of plastic through the vocal cords is the easy part. It's all the other parts that really tee them up for success, similar to when an airline pilot goes through the checklist for takeoff, right? Pulling back on the yoke is the easy part to get the plane off the ground, but all those steps beforehand to optimize that airplane before it takes off, one, ensures success, but two, that those are really the important details that we need to get right every time.
Dr. Shapiro, you want to go next?
Sure, I can go, Brendan. Let me just share my screen here, sorry. All righty. So this is a case back from about 2 weeks ago that came into Passavant. It was for an E0, a 26-year-old female who was in cardiac arrest, approximately 6 months pregnant. The downtime was unknown. The last time she was seen awake and talking was around 1,700 hours, and she's a well-known heroin user to EMS and the paramedics that were responding on the call. CPR was started by first responders, police, and QRS. She was given intranasal Narcan via QRS, and there was a needle found next to the patient. When EMS arrived, they found an unresponsive female, 26 years of age, approximately 6 months pregnant, pulseless, apneic, and warm. No history except for IV drug abuse. She doesn't take any medications, and she was allergic to penicillin and Bactrim. If we looked at the timeline from the dispatch to arrival, the call came in at 1910, which is about 2 hours after the patient was last seen conversant. The ambulance didn't get dispatched for 4 minutes, which is a little odd, but I guess this happens if they're stacking calls. Can you guys hang on a second? I'm sorry. I will handle this in 15 minutes. I'll handle it. All right, sorry, guys. So you guys started rolling the ambulance at 1916. You were at the scene at 1922, and your first EKG was at 1924, which was asystole. You then continued CPR and bag valve mask ventilation. Your IV was initiated at 26. You gave an epi at 27. You were suctioning, and we can go down the timeline. The Lucas device was put on at 1929. She was extricated to the stretcher and ambulance, and epi was given again. Now, the medical command consult was at 1938, while you guys, I believe, were still on scene in the back of the ambulance. We'll talk about that in a little bit. You continued with epi every 3 to 5 minutes. The patient was intubated at 1945. Epi was given again. Transport was at 1949. So we're in the back of the ambulance probably for about 10, 15 minutes. You arrived at the hospital at 1954. So when you guys called medical command, the timing of the call was appropriate. There was a significant delay in answering the call. 2 physicians were involved in sterile procedures, and 1 physician was in a room with a patient. The questions that were asked were about destination and closest facility versus specialty center. Now, the problem we ran into here was the physician who took the call was 6 months out of residency and he didn't know what to do. He tried to find a more senior physician and two of us were tied up in procedures. We both finished roughly at the same time and we came out of the room and the other physician looked like he was in shock trying to figure out what to do. So the decision should be, regardless of the complicating factors, the patient should go to the closest appropriate hospital. And obviously, if we had return of spontaneous circulation, we should consider a specialty center. If we would have got Rusk in the ED, we would still need to transfer the patient because she was pregnant. So this call brings many things to light. Obviously, there's a couple things we need to consider here. So if we take cardiac arrest in pregnancy, it really follows the standard algorithm. But the big difference is here is you have to remember if the fundal height is above the umbilicus, we need to displace the uterus to the left, which I couldn't find any documentation of that in the trip sheet, but I'm presuming that the crew actually did probably do that. The next issue we have is obviously we do our ABCs, high quality CPR, epi every 3 to 5 minutes, obviously standard ACLS algorithm. Ventilate the patient 6 times a minute to 10 times a minute while you're doing continuous compressions, and you don't want to overventilate. Obviously, you want to place an IV and manage the patient appropriately. If the patient was seizing, you may want to consider magnesium. However, it probably is not going to be helpful in this case. Obviously, you can't do obstetric waveforms and interventions like we can do in the hospital, but the big thing for you guys is airway breathing, circulation, and look for the etiology of the cardiac arrest. In this case, it wasn't bleeding, it wasn't cardiovascular, it clearly was toxins and drugs, and it wasn't infection or embolic issues or hypertension. But those are all things to consider. So when a pregnant patient goes into cardiac arrest, if they're preeclamptic because they're hypertensive and edematous and it wasn't managed or they seize, that's a problem. They could be sick, they could throw an embolism, they could be bleeding uncontrollably, etc. So those are other reasons that can cause cardiac arrest in pregnancy. In this case, it was pretty obvious it was IV drugs. The opioid poisoning algorithm also comes into play. The interesting part about this is it says if unresponsive, no pulse, start CPR, use an AED, and give CPR, CPR till EMS arrives. They say Narcan is okay to give, but it may or may not help in this case. So again, it's standard resuscitation in this case, but you can try Narcan if you so choose. So when we think about this call, I had a lot of dilemmas about this call after the fact because we had the medical command issue, which was very concerning to me that, when we talk about destination, we always go to the closest appropriate facility, which in this case was Passavant. My bigger concern was I had a physician who wasn't 100% sure what to do because he didn't know what to do in this case, and the crew's calling and asking for advice, and we had a nice discussion with him about that because we should always take any critical patient to the closest, most appropriate facility. Now, the other thing to think about is this was not a traumatic arrest, and if it was trauma in pregnancy, obviously the role of the resuscitation is to resuscitate the mother and not the fetus. Because if you resuscitate the mother, then you can resuscitate the fetus. But if the mother is not able to sustain life or has a better chance of survival and greater than 24 weeks pregnant, there is some literature that suggests an emergent C-section or perimortem C-section may be of benefit. But this should be done by a trained provider. Now, I'll be honest with you. I don't know any of us that truly have participated or seen more than one of these in our careers, if that. And it's pretty rare that it's done. So our goal is always to resuscitate the mother if we want to resuscitate the fetus. However, if the mother cannot sustain life or has a better chance of survival, the decision may need to be made to try and deliver the baby via cesarean section. And obviously, if it is a severe trauma where the mother cannot sustain life, a salvage C-section, if they're greater than 24 weeks, may be of benefit, and it must be done by a trained provider. Perimortem C-section. In the days of old, we did not really try to resuscitate and save the fetus by resuscitating the mother if the mother's demise was imminent. We would usually just go right to salvage section if the mother still had a pulse. Today, the fetus can cause significant strain on the mother's body after 24 weeks. So with the appropriate teams, we may be able to save 2 lives at one time. But the idea being is this is not for a cardiac arrest. This is for a almost imminent arrest where we may be able to save 2 by taking the baby and working on the mother at the same time. Well, if the mother is not salvageable, clearly, if they're over 24 weeks, a perimortem C-section may be indicated. At 24 weeks, the fetus has a 20 to 30% chance of extrauterine survival, and it does increase with gestational age. What you have to remember is the mother's relative hypervolemic state is protective to the mother. Fewer red cells are lost during hemorrhage. However, shock only manifests after 40% of maternal blood volume is lost. So, looking at this case by history, this case obviously is very concerning. It was very nerve-wracking to the crew. We did debrief the staff afterward at Passavant. But, from the crew's perspective, I completely understand. They arrive on scene, they find this woman who's in cardiac arrest. She's 6 months pregnant. They're doing everything they can. She was in asystole. Her last known well time, obviously, was 2 hours prior to the crew's arrival. Clearly, the patient was probably dead at the time of arrival, but I commend the crews for their resuscitative efforts trying to resuscitate this patient. And we did, and Mallory did do a bedside ultrasound of both the mother and the fetus, and there was no activity detected. The algorithm, the crew followed the algorithm perfectly in terms of resuscitation guidelines. I mean, I may have considered intubating her a little earlier in the house to secure the airway, but I can understand the situation they were in and why they may not have done it in that mechanism. I don't know that I would have sat in the ambulance outside the house, but that was a decision made by the crew, which that's their choice. That's not mine to get into. I would love to know why it took 4 minutes to get the dispatch out, which I don't think we'll ever know. But otherwise, most of the problems with this call were we don't see it that often. How do we manage it, which I think was done appropriately? And then what else could we do had this been a different timeline, which, obviously if the crew had got the patient back, I think McGee may have been a more appropriate facility. But since they didn't, obviously closest appropriate facility, or if the patient was in shock, closest appropriate facility. But in this case, they did the best thing they could. They did what they had to do, and I think they did a very good job. But obviously, things to consider here is if you do ever get a patient who's pregnant with trauma, you want to get them to the closest appropriate trauma center capable of handling their needs. But if a cardiac arrest ensues, you only have 4 to 5 minutes to really get that baby out before damage can start to ensue to the fetus. Because remember, the fetus relies on the mother's body for nutrition and support during its fetal growth and development. So that being said, you guys have any questions about this case?
Shapiro, I have just one question. I know back in the day, if we had a trauma in a pregnant lady, we could get away with taking them to Mercy and they could do both services. But I know Mercy kind of moved away from that. Is there anywhere that offers both services anymore?
Unfortunately, Tark, the answer is no. Mercy no longer has labor and delivery. Presby will, if they know it's coming, they'll try and get somebody up for McGee, but as well as I do, that doesn't happen very quickly. And Brendan and Phil can talk to me about Allegheny, but I don't think Allegheny has any obstetric services available. Forbes, I believe, does, if I'm correct.
Yeah, because the only reason I bring that up is because Northwest had a case the other night where they had a lady that was 5 months pregnant that was shot twice, once in the shoulder, once in the neck. And they took her to Presby. And I was curious if Presby had that where McGee could come up and help them, or what the situation was there. In our cases, would we be better off just shooting straight into Allegheny, or what would be the better course there? That's kind of what's my base of my question.
So Tark, to answer that question, Presby can get somebody up from McGee relatively quickly, or they'll transfer the patient down if they determine there's no trauma per se. Okay. But honestly, in any of these cases, if it's a trauma patient, closest appropriate trauma center. I mean, I would not pass one to get to another one by any means. If the patient's just cardiac arrest and pregnant and you do get them back, obviously, look at your options, because again, closest appropriate facility, if the mother needs stabilized, it needs to be done regardless of the fetus. So I would not pass hospitals unless you can really justify it for whatever the reason.
All right, very good. Thank you.
Yeah, and from an AHN standpoint, Turkovich, AGH obviously will take all trauma, including pregnancy, and we have a process in place that, even though we're not we don't deal with labor and delivery, we do have OB on staff, and there's a pediatrician as well. But we will, if need be, we will bring staff over from West Penn, and we have processes in place to do that. Forbes Regional Medical Center is also an OB center and a trauma center, so obviously we're not going to be transporting from the North Hills to Forbes, but for possibly that Shaler Hampton, if you have something on the turnpike, it may be reasonable to go to Forbes if the patient is stable, and that's your closest trauma center. But yeah, both Presby and AGH will take pregnant trauma. Then they both have processes in place to supplement OB staff if needed.
In the case of something like traumatic arrest, are there limitations to which facilities will perform perimortem C-sections? I've heard of one or two cases in the past where patients have been taken to smaller hospitals and the physicians refuse to engage. So,
Garrett, to answer that question, any ER physician should be trained to do it. Reluctancy is going to be your big thing, because honestly, if the patient's already arrested, by the time they get to the hospital, it's probably more than 4 to 5 minutes. The other problem is we don't have neonatal resuscitation teams at most hospitals outside of, I believe, Forbes, McGee, and West Penn. That being said, it doesn't mean we can't stabilize and transfer, but if the arrest happens in front of us, we may make the decision to try, but it will create a big conundrum if you're not in a major trauma center or a major hospital.
okay, thanks.
The only thing I would add to the region is, or to this area specifically, is we're very fortunate to have pretty heavy involvement from pre-hospital physicians that we dispatched to a pregnant cardiac arrest that is pregnant from dispatch, or a severe trauma that's involving a pregnant patient. I would have a pretty low threshold to ask county for one of the docs to see if they're available. Again, I would not wait on scene for these people, but if they're available and can get there timely, it's an extra set of hands and set of expertise that can be useful in these situations.
And Dr. Shapiro, it's Eric. Hey, a couple of things. Just wanted to kudos to the crew involved in this. They were not, there was no report from anybody on scene the patient was pregnant. It was noticed and observed by the crew during resuscitation. And kudos to you. Thanks for, there have been times in the past where certainly been involved in command issues, and you bring it forward. Not everybody always steps up, but I appreciate you stepping up and looking forward, or looking into it and addressing the issue for us.
Yeah,
it's just not the norm, so I do appreciate that very much.
Well, and, Eric, I'll be honest with you. When I listened to the tapes, I was pretty taken back. I mean, honestly, I've heard some crazy things, but I was really taken back by that.
Yeah. And the other thing, that the delay, unfortunately, is not that unusual. We had another recent cardiac arrest in the last several days where there was a 5-minute dispatch delay.
Okay.
So it's unfortunately something that is not, it happens too frequently.
Yeah. Is there a way to address that, Eric, at a systems level or county level? Because I don't get involved in that.
There is. I say so a little pessimistically, but there is a process.
Okay.
Real quick, while we're switching presenters, could I find out who 724-679-2311 is, please? If anybody figures that out, that would be helpful for the Con Ed roster. I have no idea who that is. Thanks.
All right. Can everyone see my screen?
Yes.
All right. So the case I'm going to cover today is more run-of-the-mill, something that we see quite frequently. Honestly, it's not as exciting as a cardiac arrest or an RSI, but this is something that we see, I would argue, between all of our services, maybe once a week or so, especially in the winter with slippery conditions. But so this is a case of isolated extremity trauma. This was a 70-year-old female who essentially slipped on some water, caused her to fall. She didn't hit her head. There was no loss of consciousness. She was found on the floor of the room at the home with her husband tending to her. Again, she slipped, causing her to fall. It was isolated injury. She's got an open fracture at the left tib which was visible through the wound. She typically uses a walker, and she was using it, and her legs gave out. Let's see here. That's pretty much it from that standpoint. Again, she has as a 70-year-old would, she has a number of medical problems: COPD, GERD, hypertension, hypothyroidism. Doesn't look like she's on any blood thinners. Just kind of standard albuterol, doing a Lasix, Synthroid. So nothing, at least that we can see, that would drastically increase her risk of bleeding or associated trauma. So from a physical exam standpoint, again, these initial physical exam findings sometimes can be documented pretty with the least amount of information. I would like to see a little bit more here, specifically addressing, that the head is atraumatic, that there's no tenderness to the cervical spine, there's no tenderness to the back, no other associated injuries. But from the leg standpoint, there's a clear deformity of the left leg with an open wound. The ankle is rotated 90 degrees, and we've all seen these kind of injuries. Again, this is the activity log. She's hypertensive, but she's in incredible pain. She's given 100 of fentanyl, immobilized. Now, the crew did note that they could not appreciate pulses in that extremity, and that it was cool to touch, and so lack of pulsing, they splinted it, gave her fentanyl, started transporting, took her down to AGH, got additional approval for pain medicine. Transport was essentially uncomplicated. But again, these are kind of the types of injuries that we see. We often see isolated ankle injuries like the top left. We're seeing this injury on the top right that's called a dinner fork deformity. It's commonly found in patients who fall on an outstretched upper extremity. It's also called a fouche. Typically what happens is you break the radius, the distal part, towards the wrist of the radius. Sometimes you can get away without reducing those. Other times we can just splint them and have them follow up with ortho. And then obviously the bottom two pictures are more impressive, requiring additional orthopedic surgery from an immediate attention. So from our standpoint, pre-hospital fractures, there's kind of two key components. One, we need to look for associated trauma. Often ankles and wrists are isolated and very uncomplicated. However, we do need to identify, especially in a 70-year-old who's fallen, make sure she doesn't hit her head or any cervical or pain. Looking for other injuries, because especially these nasty looking ankles or wrists can be distractors. So we need to make sure that there's no other injuries and we're not missing anything. And then the other thing is we need to look for signs of poor perfusion. So looking for a lack or diminished pulse if the extremity is cool to touch, if they have decreased cap refill, if they have lost sensation. Those are the key components. From a pre-hospital fracture management standpoint, once we have identified that there's potentially a fracture or dislocation, we kind of really only have two pathways, right? So it's either we assess the neurovascular status, and if there's a decreased pulse, decreased sensation, something showing evidence of poor perfusion, we need to give pain control and emergently reduce that extremity, and then splint and look into our secondary exam. Whereas if there's signs of good perfusion, then we can just get away generally with splinting and pain control in a secondary exam. And for those who have access to it, obviously if the fracture is open and they fit the criteria, then they can get ANSEF, which was given by our medic here. It was given 2 grams of ANSEF. That was the first Roswell case of pre-hospital antibiotics. From a state protocol standpoint, this is the protocol, obviously. In the very first box here, it talks about traction splinting for femur fractures, and then any severe angulated fracture with signs of poor perfusion need to be straightened or reduced. And honestly, it's there's a lot of hesitation with pre-hospital reduction. One, it's absolutely needed. This isn't a true orthopedic emergency if they have signs of poor perfusion. 2, it's a lot easier than what you'd think. The hardest part is going to be giving appropriate pain control, but that is the protocol itself. And then these are kind of your pain management options in terms of musculoskeletal trauma. Obviously, fentanyl Frequently, we get calls for command for approving additional doses of fentanyl, but just remember that you can give repeat doses up to a max of 300 without orders. If you switch to another class, then you need orders, but there's morphine as well. You can do nitric oxide if you have it, ketorolac, or Toradol, acetaminophen if you carry it. I'm not aware of anyone who carries IV acetaminophen, although it works great. And then ketamine, obviously. My biggest concern is if you ever give someone Toradol for this or for this, then I'm going to severely question your medical decision making. Treat the pain appropriately. So from a pre-hospital standpoint, obviously, so this patient it was a severely angulated left ankle, kind of one of those where bone's sticking out, ankle is completely 90 degrees to the other way. So before we splint that, we need to reduce it. And in order to reduce it, it's actually fairly simple. Let me see if I can pull up a video. Essentially, you're recreating the injury in the opposite direction. You're just going to put some traction on it and then go in the opposite direction of what it is. And then it's just as easy as that. Let me pull this up here. I have it up already. Let's see. Sure. So this is an ankle dislocation, obviously not a fracture. So you're going to see he's holding traction on the lower extremity here. He's going to be assessing for vascular status here, and he's essentially just going to pull traction and then recreate the injury in the opposite direction. And just like that, that's back in place. And then you can see he's reassessing the neurovascular status. The problem specifically with these ankles, when we talk about fractured dislocations, the two most common that we'll see are something called bimal and trimal fractures, where they break off the distal components of both the tib and fib. So these are incredibly unstable. And when I say unstable, is after you reduce them, they often can slip out of place again. So it's very key that once you reduce these, that you're ready to splint pretty quickly, throw on a vacuum splint just to keep that from popping out of place again. But that is essentially, from a reduction standpoint, that's as easy as it is, really. There's nothing special about it. It's just giving quick pain medication and then just traction and going in the opposite direction of the injury. It's just as simple as that. Now, you're going to have a tough time doing that. That's probably not going to get reduced. That is going to probably be a tough time pre-hospitally, just because bone is out of the wound. I don't recommend trying to lift the wound and recreate something. I would just transport emergently, but for something that drastic. But from a patient or follow-up standpoint, the patient was emergently reduced in the ER. As soon as they got there, they gave her some pain medication and reduced this. Then she was taken to the OR for internal and external fixation. She had a pretty uncomplicated discharge course, and then she was discharged. Just from a x-ray standpoint, this is a normal ankle x-ray. So this is the fibula, the tibia, and then this is the ankle joint right in here. This was her ankle after it was emergently reduced. So you can tell it's still not good. She had a trimal fracture. This is a piece of the tibia that broke off. You can see the fibula. It's still dislocated and not in place, but this was after emergent reduction. So it was worse than this. But this is what helped gain the vascular status back. And then just from an operative standpoint, this is what happened after they repaired it. This device is the external fixation. This is the internal fixation. And she did really well. So the key takeaways is with these isolated ankle fractures, you want to make sure that you're not missing any additional injuries, but two, assessing the neurovascular status. And if there's any evidence of poor perfusion, then we need to reduce that fracture dislocation as quickly and as best as possible, and give appropriate pain control and splint it and take to a receiving center that can manage these types of injuries. Other than that, I know it's not as exciting as a cardiac arrest or an RSI, but this is something that we see quite often. We may not see evidence of poor perfusion often, but we see these isolated injuries almost weekly, especially during the winter. So it's nice little review. But with that, if anyone has any questions, let's.
How does pulse palpation in the foot compare to applying a pulse oximeter to one of the toes in terms of being able to assess perfusion status?
So I generally would not rely on a pulse oximeter. I would go for actual palpation of the pulses, just because the pulse oximeter can probably pick up some residual oxygenation and perfusion. But I would feel for a dorsalis pedis, which is the foot or the pulse on the top of the foot, and a tibialis posterior, which is on the inside behind the medial malleolus. If you are unable to feel any of those pulses and the foot is cool and they're having severe pain, then I would perform a reduction. Nothing else. I think that's about it. I think we're just covering 3 cases today. So if no one has any other questions, I believe we're wrapped up, and see everyone next month.
Does anybody have any questions for any of the 3 presenters?
Thank you all.
If Steve McGinnis had texted me the names of the folks that are in attendance at McCandless, if any of you have anybody else watching that's with you, if you could just shoot me a quick text so I can add them onto the roster, I'd be happy to do that. Thank you all for calling in. The attendance was excellent. Cases were good. We'll be back together again the first Monday of March.
Thank you.